This is Keegan Mechels from Oculofacial Plastic and Orbital Surgery in Carmel, Indiana. I'll be demonstrating an alternative approach to the traditional lateral canthotomy and cantholysis for orbital compartment syndrome. Please note that this video utilizes a donor cadaver. First, I will show the traditional lateral canthotomy and inferior cantholysis. The lateral canthotomy is performed here using a 15 blade, starting from the lateral canthus and extending to the lateral orbital rim. This step may alternatively be performed using a westcott scissors, tenotomy scissors, or straight iris scissors. Additionally, you may clamp the lateral canthus with a hemostat prior to cutting to encourage better hemostasis, though this is not required. Next, the inferior cantholysis is carried out with one hand gripping the inferior lid margin and the other using straight scissors pointed toward the patient's opposite shoulder. The inferior canthal tendon should feel more taut than the normal surrounding soft tissue, and you will know it is released when the eyelid gives way and you can no longer strum across more firm tissue. Not shown in this video, the superior cantholysis can be performed in a similar fashion to further decompress the pressure within the orbit. In this second part, I will demonstrate an alternative vertical lid split method used to address orbital compartment syndrome. Here, the upper eyelid is retracted from the globe using forceps to avoid injuries to the eye. Alternatively, you could place the forceps backwards underneath the eyelid to ensure that there is no touch to the globe. A full thickness upper eyelid incision is made using tenotomy scissors or straight iris scissors, 3 to 4 millimeters from the lateral canthus and extending 8 to 10 millimeters away from the lid margin. If the IOP does not adequately decrease, a corresponding 7 to 8 millimeter incision can be made in the lower eyelid. This technique has been shown to adequately decrease ocular pressure, particularly in cases when the traditional canthotomy and cantholysis cannot safely be accomplished in a timely fashion. Once the patient is stabilized, the eyelid incision can be moisturized with ointment and repaired by an oculoplastic surgeon within 5 to 7 days.